Everyone, this is Dr. Mike Gornacha here at New England Fertility in Stamford, Connecticut, and today I wanted to talk about egg donors, how we interact with egg donors, and what they go through, the treatments that egg donors undergo when they generously opt to donate their eggs to couples. We all many questions for me that have come up in the past. So here at New England Fertility, we offer egg donors for couples, both same-sex couples and heterosexual couples who require an egg donor. Now, what's great also is here at New England Fertility, we have our own database of egg donors, and we also liaise or work with other egg donor agencies. So we have the best of both worlds. And I think that's important simply because if you're a couple looking for an egg donor, or even a single person looking for an egg donor, we all have our goals in terms of what we would want in an egg donor, and you may find a great egg donor through New England Fertility's database, or you may use one of the other agencies that we work with. And, I think it's most important that you use an egg donor that really feels, like organic to you and has what you're looking for. So how it works is that once you've identified an egg donor, we will have that egg donor come in and she'll undergo screening. Because once again, I have to stress that as the physician taking care of the intended parents, it's also my responsibility to take care of the egg donors to the best of my ability. So we still want to do medical screening on the egg donor to make sure she's healthy enough to be an egg donor. Also, some of our couples will find an egg donor and they'll send the profile to us and say, is this somebody that we think is a good candidate to be an egg donor? Now, in terms of, that brings up a topic, what's a good candidate to be an egg donor? Well, we have a preference that we like our egg donors to be in their mid-20s. We have a range of ages. And we will also do hormonal and ovarian reserve testing on them to make sure that when they go through the egg donation process, that they'll produce a good number of eggs. We want to safely stimulate the donors so that they produce a good number of eggs. We also don't want to overstimulate the donors. So by doing what we call ovarian reserve testing, we're able to gauge that sweet spot, so to speak, in terms of the medication that the donor is going to be on and getting safely good number of eggs for the intended parents. And for a lot of our gay male parents, they're going to be dividing the eggs 50-50. So one of the partners is going to be fertilizing half the eggs, the other partner is going to be fertilizing half the eggs. So once again, not to overuse that expression, but we want to find the sweet spot in terms of ovarian reserve that we're going to have an adequate number of eggs for both partners to fertilize. And the age of the donor also is important simply because we know biologically as a woman gets older into her mid or late 30s and early 40s, she may have a good number of eggs, but the quality of the eggs goes down. So I think, as I said, we want to look at a couple of parameters: age, ovarian reserve, and overall health. The donor will come in for screening here to New England Fertility, and then once she's been cleared to proceed as an egg donor, she'll then be set up to go through a cycle. Now, as you may or may not know, that especially for our gay male couples who are going to also be using a gestational carrier, otherwise known as a surrogate, there is some pre-testing that needs to be done on them as well. And this is called FDA blood testing and also a semen analysis. But that would be arranged before you've chosen an egg donor. Also part of that testing will be what we call carrier screening. And that's designed to look at recessive genetic mutations. We all carry something based on our ethnic or racial background. So we test the intended parents to see if they carry anything. Once that result is back, then you can finalize an egg donor because they've already gone through that testing, either through the egg donor agency or here at New England Fertility, simply because you want to avoid an egg donor that may carry a similar recessive mutation that one of the intended parents carries. Or if it's a heterosexual couple, we will test the male of the couple to see if he carries anything, and then that would be avoided in whatever egg donor you choose. In some situations, we have patients who come to us who will say, my friend or an acquaintance has offered to provide eggs to be an egg donor, and that friend or acquaintance would still need to fulfill all the requirements that we require: medical screening, genetic carrier testing, and then also an AMH level or ovarian reserve testing, because obviously we know that some people are gracious enough to offer to donate to friends or even relatives, but we also want to make sure that it's going to be a good outcome for everyone involved. So fast forward, donor has been approved, we're all ready to get started. The clinical team would then reach out to the donor to confirm when they're able to go through a medicated cycle, and we'll arrange to have her start the cycle. Now, another great thing is that here at New England Fertility, we actually liaise with multiple centers throughout the country. So your donor does not need to be here in Stamford, Connecticut, or even in the tri-state area in order for us to work with her. So once we know where geographically the donor is, we'll arrange to have her undergo ultrasounds and blood testing in her local area. We will start her medications, and then once she's well into the cycle, she'll come to Stamford for the egg retrieval. And that's, once again, backing up a little bit. Any person who's an egg donor will start the injections. They're hormonal injections. We call them gonadotropins. And these are designed to get the eggs in the ovaries to develop. So biologically speaking, we know that every month a certain number of eggs or follicles start developing. Those are called antral follicles. And the way IVF has been practiced for the last 30, 40, 45 years now is that the medications that the donor takes will get those follicles to grow and develop. Within each follicle is an egg. Normally, a woman will produce only one follicle a month that she ovulates out. But obviously, as part of the IVF process, we want women to produce multiple follicles, hence the need to use injectable fertility medications. So once again, the donor gets started on her medications. Now, I'm frequently asked in terms of, how often is the donor needing to have blood tests and ultrasounds to confirm that she's responding to the medication? Well, what I always tell patients is it doesn't have to be every day. That's not necessary, because we know the medications take a couple of days to kick in and get the follicles to start growing. So what I always like to tell patients, donors, and the intended parents is that most egg donors will require about 10 to 12 days of medication in total. And normally she will undergo at least 4 ultrasounds in that 10 to 12 day period, with an eye towards maximum safety for the egg donor in terms of the ultrasound, what we expect to see, and her estrogen level, which is what the blood tests are designed to measure. And both of those tests, the ultrasound and the estrogen level, are designed to tell me how the donor is responding to the medication, how many follicles she's producing, and what our expectation is for number of eggs that we'll be able to retrieve. Additionally, by tracking her estrogen and follicle growth, we're able to determine the optimal time to retrieve those eggs. As I said, in most cases, it's usually after about 10 to 12 days of medication. So your donor's been on medication, she's responding well, then you'll get a call from your coordinator here at New England Fertility and the nurses to say that your donor's going to undergo an egg retrieval. She takes the trigger shot, and then 36 hours after the trigger shot, she'll undergo an egg retrieval, which is a sedated procedure in our operating room where we extract the eggs vaginally. So I always tell donors, there are no incisions on your abdomen. It's all done vaginally. The procedure takes 15 to 20 minutes, and sedation is provided by qualified anesthetists. Retrieval is done. She wakes up. She goes to the recovery room. We monitor her for at least an hour to make sure she's doing well, and then we discharge her. Now, for a lot of our donors who aren't in the tri-state area, we'll ask them to come back the next day to make sure they're feeling good, they're feeling fine. They'll get ultrasounds, we'll check their blood levels just to make sure that they've done okay after the retrieval before they head back to wherever they're from. Once those eggs are retrieved, the embryologists assess them and evaluate them, and then they're combined with sperm and placed back in the incubator to sit overnight. The next day, the embryologists remove them from the incubator to assess them for fertilization. And as I said, for same-sex male couples, in most instances, it will be half the eggs are fertilized with one sperm source, the other half with the other sperm. So for heterosexual couples, it will be one sperm source. And that's really it from that perspective. Now, the process of egg donation has been part of the IVF world for many, many, many years, and its safety has been well validated. Sometimes the donors will ask me, well, doc, I'm donating my eggs. Does that mean when I'm ready to have a baby, I will have less eggs in my ovaries? No. And simply because, number one, we have 30, 35 years of experience to tell us that. Number two, we know that every month a certain number of eggs start developing, or a certain number of antral follicles within which are immature eggs. One egg ovulates out, the other antral follicles degenerate away. So the ovaries go through this programmed egg loss over time as a woman ages. All IVF is doing is taking advantage of the antral follicles that develop that month. We're not digging into, your savings account of eggs. We're just making do with what develops that month, which is why knowing a woman's ovarian reserve and doing that testing is so important, so that we can make sure that the egg donors have normal ovarian reserve. Occasionally, we've come across women who want to be egg donors, and we've done our testing, and we said, your ovarian reserve is a little bit low. You won't qualify as an egg donor, and you should also know so that you can take that into account for your own future reproductive goals. So that's always a big question that I'm asked is, am I digging into my supply of eggs that are going to affect me in the future? And the answer is no, based on long-term data and based on the biology of the ovaries that we know. Good. Other issues in terms of using egg donors, as I said, with a majority of the egg donors, we would like them to be in their 20s, within a certain age range. And the expectation is that they'll have a high number of chromosomally normal eggs and eventually embryos, simply based on their age and their ovarian reserve. And Marissa has a question. We will. And if anyone else has any other questions that I can answer for you, obviously, if there are other questions that come up after we're done, certainly scheduling an appointment here at Fertility. Yes, Marissa.
Hello.
Hello.
We have some questions for you.
Awesome.
So, how how does egg donor safety how is egg donor safety managed in real time?
I mean, egg donor safety is managed primarily making sure she's a good candidate, that it's safe for her to be an egg donor, and that's part of the vetting process. That the agency will start that process. If it's a NEFI, New England Fertility donor, we do that process. But even if it's an agency donor, we still have to approve that it's safe for her to, number one, be an egg donor. So that's issue number one. Issue number two, determining her ovarian reserve with the AMH blood test and the antral follicle also helps me to prescribe the appropriate amount of ovarian stimulation medication, so that we're not overstimulating her or purposely hyperstimulating her. So that's where the ovarian reserve testing is important, because based on those results, I'll triage the medication dosage to get a good response, but not an over response. That's number two. Number three, once she's in her cycle, she'll be getting estrogen levels, blood tests, and ultrasounds to clarify, A, is she under responding and do we need to increase her medication? Or B, is she over responding and we need to decrease her medication in order to minimize the risk of what's called ovarian hyperstimulation syndrome.
Okay, that's really helpful. So, how do hormone levels and ultrasound findings work together when you're deciding to adjust medications?
Well, so we each, I think based on my experience, based on Dr. Levy's experience, and based on the experience of wherever your donor is working, the doctor will adjust it based on the level. So our expectation is that when a patient comes in for monitoring, she will have been on 4 to 5 days of the shots. She comes in. The expectation is that her estrogen level will be anywhere from, I mean, it can vary anywhere from 250 to 300 or greater. But that's also going to vary based on the donor's age and her AMH level and what the ultrasound looks like. We know that each developing follicle produces a certain amount of estrogen, and that will be seen in her serum estrogen level. So I think part of the art of IVF treatment, donors are no different than patients going through IVF for themselves. Part of the art of doing this is sort of looking at the donor, assessing her, doing her ultrasound, seeing how many follicles there are, then looking at her estrogen level and saying, no, she's doing fine, takes the same dose, comes back in 2 days, or, let's decrease the dose a little bit and then reassess in 1 to 2 days.
Okay, and then if you're going through the process and you have any physical symptoms, is there anything worth reporting to you
Well, I asked you,
about?
well, so let's back up a little bit. What are
Hmm.
physical symptoms that could be expected or anticipated in somebody who's on these medications? Not just the donors, but even women who are, extracting their own eggs. There can be some bloating. Okay, this is estrogen, and it can cause a little bit of abdominal pelvic bloating. We're also making the ovaries larger because we're getting multiple follicles to develop. So that also contributes to the bloating. Some women will say, I'm having some mild headaches from the estrogen. Um, and I always tell patients to report whatever they're feeling. Like when I walk in the room to do an ultrasound, first thing I'll say is, how are you feeling on the medications? Anything to report. Extreme symptoms that I would want to know about right away would be any sort of visual changes, anything that might lead us to be concerned about other issues, chest pain, shortness of breath, um, things like that. Those are call your doctor's office immediately, or persistent nausea and vomiting. Some of these medications, the rise in the estrogen can lead to a little bit of nausea. So I always ask patients to report everything to us. And what's great is that we are here at Neffy, they'll have their coordinators that they're in touch with constantly. So they can report it to their coordinator, and then they report it to us, and we just reach out to the patient. Chest pain, shortness of breath, visual changes, anything like that is report immediately. Mild symptoms, you still report it, and then we'll work with you to try and ameliorate those symptoms with hydration and things like that. And what I always clarify to patients is that those symptoms are due to rising estrogen levels, and then once they have had their eggs retrieved, after a couple of days, their estrogen level starts to fall. Those symptoms should resolve.
Okay, great. Those were all the questions that we had.
Excellent. All right, very good. And I really think, I think the journey of using donor eggs is obviously one that, for some couples requires them to think seriously about it, to understand the process. But I think nowadays in 2026, we're fortunate that there are plenty of women who would like to donate their eggs. So there's a wealth of opportunities for patients, for what we call intended parents, to seek out egg donors that are going to, work with what they're looking for, what their expectations are. Good. I'm going
Great.
to I'm going to sign off now, everyone. Thank you very much for listening. Take care.